everyone. So today our speaker is Dr. Lori Gawron. Dr. Gawron is an assistant clinical professor of obstetrics and gynecology at the University of Utah. Today, Dr. Gawron will speak about providing contraceptive care to clients with chronic conditions. Thank you for joining us.
Thank you, and thanks for everyone for signing in over your lunch hour to do this. Just flip through slides. Just as a disclosure, I am a principal investigator on several studies that are funded by industry, but these do not lead to any conflicts in the information I'm speaking about today. So this is my personal introduction slide. I'm an assistant professor here at the University of Utah and a family planning specialist. I've been at the university for just over 4 years. I'm also the gynecology section chief at the Salt Lake City VA, and so I provide care to women who have many chronic health and mental health conditions for whom complex contraception is an important discussion with them. So my learning objectives over the next 40 minutes or so are to review U.S. pregnancy intention data. Some of this I know you've seen before in previous slides, so I'm going to try to make it specific to the chronic disease population. Also discuss chronic disease burden, both nationally and in our local population. And then talk about contraceptive decision-making in the setting of chronic disease, taking into account characteristics such as efficacy, safety, acceptability, and availability. So let me start with reproductive planning. What does this mean? Most women across the U.S. want an average of 2 children throughout their reproductive lives. And in order to obtain the 2 children, they spend about 5 years either trying to become pregnant, or recently postpartum. They then spend approximately 30 years of their reproductive lives trying to avoid pregnancy when it doesn't fit into their social plans, or their life plans, or their chronic disease planning. Often women, as they get older, are diagnosed with chronic health conditions, and these need to be optimized before planning for another pregnancy. We also know that unintended pregnancy is associated with adverse pregnancy outcomes, including preterm delivery, low birth weight babies, increased risk of miscarriage in some settings. But you can imagine if you're a chronic disease patient, an unintended pregnancy may impact your disease prognosis. For example, if you're a breast cancer patient who has a pregnancy that happens during treatment. If you are a hypertensive patient, this could affect your own personal health outcomes if you then have severe preeclampsia in pregnancy, or the worst outcome would be a stroke in these settings. And it could also affect the baby too. If you have poorly controlled diabetes, the baby could be affected with a congenital abnormality such as a heart defect. Unfortunately, though, nearly half of all pregnancies in this country are unintended, meaning they're either mistimed, or the woman wants pregnancy at some point, but not in the next 12 months, or they're unintended and says that she does not desire pregnancy at any point during her reproductive life. And the awesome way of preventing unintended pregnancy is through consistent and correct use of contraception. So you've probably seen this slide in previous discussions, but of the women who use contraception consistently and correctly, they account to only 5% of the unintended pregnancies in this country. So if we really want to move the bar on unintended pregnancy and resultant abortions, increasing access and correct use to all forms of contraception to meet a woman's needs is really the most effective way. So let me move on now and talk about the chronic disease burden in reproductive age women. We know that the prevalence of chronic health conditions is increasing in reproductive age women. And this is partly due to the obesity epidemic and the associated diabetes and hypertension that we see with increasing body weight. It's also related to increasing autoimmune disease prevalence. Also, in pregnant women, we know women are waiting until they're older to get pregnant, and so they're more likely to have been diagnosed with a chronic health condition before that pregnancy occurs. And despite my idealistic view that women with a chronic disease want to optimize their health before they become pregnant, unfortunately we do see that women with chronic diseases are more likely to have an unplanned pregnancy. And we'll talk about some of the reasons for that shortly. So in the setting of a chronic health condition, pregnancy really must be planned, because we know that pregnancies that occur at the time that the disease is more active are more likely to be associated with recurrent flares of disease in pregnancy, miscarriage, preterm delivery, low birth weight, in addition to those adverse outcomes associated with unintended pregnancy, because many of these women may not know that they're pregnant and delay prenatal care, and so they're already into the second trimester and their diseases are not optimized. So which chronic conditions are we really talking about? Well, one resource that we have that lists a number of chronic conditions is the CDC medical eligibility criteria for contraceptive use. And this was originally published in 2010 and updated in 2016. And it came from a document that was modified from the WHO. And in this 2016 guidance, we have 21 health conditions for which the risks of an unintended pregnancy are really concerning, and so they recommend that highly effective contraception such as IUDs or implants would be first line for these patients who are at risk for pregnancy and have not had a sterilization. And so things such as breast cancer, epilepsy, lupus, etc., an unintended pregnancy could definitely adversely affect the treatment, the disease, or the pregnancy itself. So how common are these conditions? Because many of you probably aren't seeing many patients with sickle cell disease in the Utah population, at least. Well, one study tried to look at the prevalence of these diseases in reproductive age women, and they looked at privately insured women over several years, and these women had to be insured for 5 consecutive years so that they could see that a woman was diagnosed with one of these conditions. And I'm going to put up a list of a lot of numbers. The goal of this is not for you to read every number, but just to see kind of the top conditions out of that CDC diagnosis categories that came up in this population. And then across the top line, we can see the prevalence of any condition. And so of the 368,000 women who they included in the study, approximately 12% have one or more of these chronic health conditions listed by the CDC. And it increases with age. As you can see in the younger cohort of the 15 to 34-year-olds, approximately 5% have one of these conditions. And as women aged into the 35 to 44-year decade, went up to about 21%. Now, the most common conditions are actually not that common. You can see even in the older age group on the far right for hypertension, it's still only 15% of this population has it. And many of these conditions represent less than 1% of the population. But the numbers on here show that it still affects thousands of women. And these are women of reproductive age for whom pregnancy considerations and contraceptive care are important. In the same study, they looked at how often women were using what would be the first-line CDC recommendation of LARC, or long-acting reversible contraceptives, IUDs, or implants, compared to short-acting methods such as pill, patches, or rings, no method, and this doesn't mean no method at all, but no prescription method, so they could be using condoms or other barrier methods, and sterilization. And then they broke down whether women had one of these disease categories versus those who didn't, and by age group. And what they found is that in the younger cohort, women who have one of these diseases, over 50% of them still were not relying on any effective prescription level or device level form of contraception. And in the older age group, it was nearly 70%. And so despite the CDC recommendations for highly effective contraception, we're not seeing that play out in the chronic disease population. The other issue that comes up in defining chronic diseases is, as I showed you, these are not that common in the populations that you're seeing, especially if you're a generalist who sees primarily healthy young women. You're not seeing thrombogenic mutations that often. So what about all the other chronic health conditions that are more prevalent in reproductive age women and we see more commonly in our practices, such as depression, substance use, obesity, some of the autoimmune diseases that are more common in our everyday care? How commonly are we seeing these, and what is the actual prevalence? So our group looked at Utah data, including those other categories, and we actually found that 1 in 3 of the women that we're seeing have one or more of these chronic health conditions. And so even though those numbers are small on that first list, we are still seeing diseases that need to be modified before pregnancy in order to optimize health outcomes. So why aren't women using contraception in these chronic disease settings? Well, there are a lot of reasons. Often women are overwhelmed with just prioritizing their disease management over contraception. They're more worried about getting their immunosuppressant agent for their autoimmune disease and the side effects of that, and they're not really thinking about the need for contraception to avoid a pregnancy when their disease is flaring. They're also getting a lot of contraceptive misinformation, concerned about side effects and risks, And much of this is on patient support groups, but also comes from providers telling them that they're not sure, they don't know, and they don't think certain contraceptive methods are safe in the setting of the chronic disease that the woman is asking about. And so we often lead to this confusion around preventing pregnancy, whereas often the worst outcome is an unintended pregnancy because the woman wasn't using the contraceptive that we were talking about not being as safe. Another concern that patients have with chronic disease is this sense of perceived infertility. Many of them believe that because they have this chronic health condition that they can't get pregnant or that it's harder to get pregnant, and so if a pregnancy were to occur, that would be a good thing. And so talking to patients about making sure that if a pregnancy were to occur, it's at a time when their disease is optimized and they're ready for it in their life is really ideal, because often many of these diseases, while they may impair regular ovulation, do not necessarily impair fertility and lead to a true diagnosis of infertility. Another concern that women have is avoidance of polypharmacy. They're already on so many medications to manage their chronic health conditions, they don't want to add one more. And this is where talking to women about the different types of contraception and how it doesn't necessarily mean taking another pill is important. And finally, one of the things that we really need to do is break down some of these silos of care. You know, women will often see their oncologist if they have breast cancer, who they ask about contraception or pregnancy planning, and their oncologist will say, well, I'm not sure, you'll need to go talk to your primary care doctor about that. And they'll go back to their primary care doctor, and their primary care doctor says, well, I'm not sure in the setting of your chronic disease, you should go talk to your OBGYN about that. And so they get bumped around and don't really get the information that they actually need because no one is taking ownership of the reproductive planning for these women. Okay, so let's move on to contraceptive decision-making in the setting of chronic disease, and first talking about efficacy. So you may have seen this table before of a breakdown of efficacy of the different types of contraceptive methods that we use here in the U.S., and this comes from bedsider.org, which is a great patient-facing education tool. And regardless of whether a woman has a chronic disease or not, I always talk to patients about how effective different methods are and how they're not all created equal. And this is another misperception by healthcare providers too, where they'll ask women, well, what are you doing to prevent pregnancy? They say condoms, and they're like, okay, that's fine. But really, if your chance of getting pregnant is about 18% over 1 year of typical use with a condom, and you have a chronic health condition where you really should not be pregnant at this time, then that's not an acceptable failure rate in this population. And so we need to do a better job as providers of making sure women understand the differences in these methods. So the top line are the highly effective methods: sterilization, and then the long-acting reversible methods, such as the contraceptive implant and the hormonal and non-hormonal IUD types. The middle tier are the short-acting methods: the pills, patch, the ring, the shot. All of these are hormonal-based methods, and they're all very user-dependent, which is why they have a higher failure rate for some women. And finally is the lowest tier for efficacy, but the one that has the fewest side effects. If women are concerned about using a method that might interfere with her medications or chronic disease symptoms, these are withdrawal, fertility awareness, and barrier methods. Now, what's in each of these methods? And this is where it's really important to have this knowledge if you're going to talk to women with chronic health diseases about what's best for them. Now, the efficacy is important for those CDC diagnoses especially, and so the top tier, IUDs, implant, sterilization, are often the first line, not only because they're the most effective, but often because they're the safest for women with chronic health conditions. For those that have hormones in them, the only hormone is progestin in the IUD and the implant, so there is no estrogen in each of these methods. And that's the one that we're the most concerned about for many chronic health conditions, as I'll go into more in just a minute. The only ones that have estrogen in them are combination birth control pills, the patch, and the ring. And so you can see the shot is on that middle tier as well, and that's another progestin-only method option, and there are also the progestin-only pills, which do not have estrogen in them. And so these are the two hormones that encompass all of the different hormonal methods that we have on the market. And these are their actions and why they're in the hormonal contraceptive methods. Now with estrogen, any of the estrogen-based methods, the combination pills, the patch, the ring, in the U.S. typically have ethinyl estradiol in them. It's a synthetic estrogen, and it's the same in all the methods. What changes is the type of progestin. And so you'll see different progestins in each of the different methods, such as the hormonal IUD and the implant compared to what's in the pill, patch, and ring compared to what's in the shot. And so this is a breakdown of the different types of progestogens. And on the far left, under the progesterone category, you can see medroxyprogesterone acetate, or Depo-Provera, is the only progesterone in that class that we use as a contraceptive, and that's in Depo-Provera. Whereas if you look in the middle category in the far right, you see norethindrone, you see levonorgestrel, you see drospirenone. These are all different types of progestins that are in birth control pills. And levonorgestrel, which is the hormone that's in the hormonal IUD, is also in birth control pills. And so if patients are getting side effects on short-acting methods, it's moving them between these different categories of progestins that can sometimes improve side effects as opposed to changing the estrogen, which is pretty much the same in each of them. So with that as a broad overview, let's talk about safety of these methods. And the reason I talked about the different breakdown of the hormones is because often it's the estrogen that's the concern. So how do we know what's safe based upon the different diagnoses that women have? Well, going back to the U.S. medical eligibility for contraceptive use, this is the overview of it, and where you can find it online if you're searching for it. But what this is it's evidence-based guidance for contraceptive safety for U.S. women with specific characteristics and medical care and medical conditions. And so, like I said, it started with WHO. It was modified by the CDC to meet our population. New diagnoses were added that were specific to the U.S., such as inflammatory bowel diseases, bariatric surgery, transplants. And then when it was updated between 2010 and 2016, cystic fibrosis was also added. So what is this and why do we use it? Well, this is our clinical guidance on complex contraceptive use. It can answer different questions, such as can a breastfeeding woman use the shot? Can a woman on seizure medications use the patch, etc.? And you can see on the bottom right, that's what the app looks like. If you download that to your smartphone or tablet, if you go under in the App Store and search for CDC Contraception, this is the one that comes up. And it's a combination of both the medical eligibility criteria, but also the SPR is the other abbreviation that's on that app. That's selected practice recommendations. And so this can tell you, how do I start a method? Are there any specific tests I need? How can I be reasonably sure that a woman is not pregnant? And so if you don't already have this app, download it, go through the different guidance in it, because it's really, really helpful in your day-to-day clinical setting. When it comes to the medical eligibility criteria, the way the CDC has ranked the different safety options for these contraceptive methods based upon the category they're in is 1 through 4. So remember that this is expert guidance. This is not always rigorous, randomized controlled trials supporting evidence on safety, because some of these we don't have great data on whether or not it's safe in the specific medical condition with the specific method. And so we do often have to extrapolate data, and that's why we have this range of categories. So category 1 means we have decent data, and there is no restriction on the use of this method in the setting of this chronic health condition. Category 2, the advantages generally outweigh any theoretical or proven risks. And so often this just means that we don't have as much data, but overall we're not seeing any case reports or concerns about safety of the method in the setting of a chronic health condition. Now category 4 means don't use it because it's not safe, and we have data proving that. Category 3, going back to that, is where things get a little bit harder, and you have to maybe seek out some additional information. So category 3 is theoretical or proven risks usually outweigh the advantages. And so, for example, let me give you a breakdown of what some of these conditions look like. Now, if you look on a desktop, you'll see this large summary table of all the different conditions on the far left, subconditions, and then the different contraceptive methods across the top, the copper IUD, levonorgestrel IUD, implant, depo, progestin-only pills, and then the far right category is CHC, that's combination hormonal contraceptives. So these are the ones that have your estrogen in them. So the combination pills, the patch, and the ring. And then the next gray line underneath that, the I and C, that means are you initiating the method Or are you seeing somebody who wants to continue the method who's already on it? Because sometimes those recommendations vary. And then they color code this along with their numerical classification. So you can see, for example, the top row, diabetes, a history of gestational diabetes. All of these methods are category 1. So they are safe. We have good evidence showing that they are safe to use for any of these options. But then you get down into, say, the bottom for endometrial cancer. You don't want to initiate an IUD in a newly diagnosed endometrial cancer that has not been treated yet. Whereas continuing a method if somebody who's already had endometrial cancer treatment is a category 2. Now on the far right, look at neuropathy, retinopathy, nephropathy. You see the 3/4. And so what this means is that there's some additional guidance based upon the asterisks you see on there. And you need to get some more patient-specific information about how severe their disease is, and then consider it in the context of using these methods. For example, if a woman will only use a combination birth control pill as her method, and the alternative is pregnancy, there is a potential that the pregnancy is much riskier compared to using estrogen to prevent it. And that's because of the concerns over estrogen. You know, when we look through the guidance on these different methods, it's often concern for estrogen and increased risk of venous thromboembolism, MI, or stroke. And so this is a breakdown of data looking at the relative risk of using a combination oral contraceptive, so this is specific to the pills with estrogen, compared to baseline. And so the relative risk of just walking around at baseline and having a venous thromboembolism is 1. And yes, use of estrogen-based oral contraceptives does increase your risk 2 to 3-fold. But this is 1 to 3 per 10,000 reproductive women per year. And so the risk is still extremely low. But when you look at the risk of pregnancy, this is where you really see the increased relative risk. And so if the alternative, again, is pregnancy, potentially the estrogen-based contraceptive is still the safer option. And when you think about chronic disease patients, many of whom are already at risk for venous thromboembolism, adding in a pregnancy definitely increases their risk. And this is where you have to have a risk-benefit discussion with each individual patient. Now, what about progestins? There's been some concern, both in the lay press as well as literature, about whether different progestins can increase risk of thrombosis. And so Tepper published this paper in 2016, which is a systematic review on thrombosis risk and progestin-only contraceptives. So again, these are progestin-only pills, Depo-Provera shot, the implant, and the hormonal IUD. And what they found is really no increased odds with any of these methods, except for some studies that had some conflicting data on the use of Depo-Provera and potentially the increased risk of venous thromboembolism in the setting of Depo-Provera use. But because the numbers were small, they were confounded by the risks of these women's chronic health conditions. Their take-home from this paper is there is no overall increase in venous or arterial events with use of progestin-only methods. And so even in a patient who's had a prior blood clot, it is still safe to use these methods over estrogen-based method. So let me move on now and speak about acceptability of these methods. And this is where these conversations are sometimes evolving with patients with chronic diseases, because often you have to overcome first many of their misconceptions about methods and safety and tolerability, and also educate yourself on the definite risks that are associated with their chronic health condition. And so when you talk to patients, you definitely have to go through the side effects of the method. And this is true whether a woman has a chronic health condition or not. You need to talk about potential for bleeding or weight gain or acne. They may have more cramping if they have an IUD in. Now, sometimes the side effects can be positive, and sometimes they can be negative. An example of this is with the hormonal IUD, you're going to have some irregular spotting initially for the first several months. But for a patient who previously was hemorrhaging each time she had a cycle, that irregular light bleeding might be a positive side effect. Whereas for the patient who really wants to have the regular, predictable menstrual cycle, the irregularity of these progestin-only methods may be a significant negative side effect for her. And so setting up expectations of these methods is really important. It's also important for chronic disease patients to ask them what their symptoms actually are related to their disease. For example, a woman with inflammatory bowel disease who gets a lot of pelvic cramping and pelvic pain related to her symptoms, she may not desire an IUD, which is going to increase the risk of cramping, even though her bleeding might be better controlled. And so asking about side effects of the disease and then putting them into context with these different methods is important in getting patients to understand what to expect and potentially continuing with it if it's a known entity going into it. The next important thing to talk about is birth spacing and pregnancy planning. Now, I see many chronic disease patients who want to be pregnant right now, but they recognize that they need several months to become more stable on their medication. And this is even true for our mental health patients that we see who are maybe switching from one medication to another in order to control mood symptoms. We would like to see them stable on their medications for about 3 to 6 months. And so using a form of contraception to prevent pregnancy while their disease is optimized is important. It's also important for birth spacing. So many of our chronic disease patients alter their medications or their treatment in order to have a baby, and then they know that it's going to take some time afterwards to recover from that pregnancy, optimize their health again, make sure they're again on safe medications, and then plan for another pregnancy. So even in the context of the chronic disease, that's important. But also in a healthy woman, we know that the optimal birth spacing is about 18 months from delivery to conception. And so talking about recovery, breastfeeding, if a patient had a C-section, that we need to heal the scar, these are all important aspects to promote safe contraceptive use in these patients. Another important acceptability part is the partner. If a patient feels that she has to gain partner approval for her method, bringing that partner in and talking about the risks and benefits and side effects and safety are really important, because if the partner does not want her to continue a method, and that it's going to affect their relationship. And so we need to make sure that everybody's expectations are on the same, are in line with our goals of pregnancy planning. And then there's another really important part of this called non-contraceptive benefits. There was a study by the Guttmacher Institute years ago that found that approximately 12% of women who were using birth control pills were using it for reasons other than pregnancy prevention. And for those of you who prescribe contraception, we've been doing this for a long time, whether it's to make bleeding go away because they have heavy periods or they don't want to have periods. There are a lot of benefits to contraceptive use that aren't specific to just preventing pregnancy. And so these are some of the contraceptive benefits that we prescribe for. Cancer reduction, ovarian, endometrial, colorectal cancer reduction with some of our hormonal methods. Cycle-related conditions, we often use hormonal methods for managing heavy menstrual bleeding or endometriosis. Our estrogen-based methods can prevent bone loss. We can also see decrease in breast disease, fibrocystic benign breast disease, with use of estrogen-based methods. And our dermatologists frequently prescribe birth control pills with estrogen in them in order to decrease acne in conjunction with other ways of managing that. We have some ways of managing hirsutism or extra hair growth, and also menstrual-related migraines. We've known for many years that putting patients on hormonal contraception decreases their migraine burden as well. And then another important part of this is disease-related benefits. For example, women with epilepsy, I often have them track their seizure activity if they're not feeling well controlled. Many of them will have seizures that cluster around the time of their menstrual cycles, and this is because their hormonal levels are changing in response to their cycle, their estrogen levels are falling, and so their seizure threshold changes, and their seizures will cluster during their menstrual cycle and then get better during other phases of it. And so by tracking their disease-related symptoms, we can figure out, okay, if I shut down ovulation, or if I make sure that the woman is getting the same level of estrogen each day through birth control pills, or if I use something like Depo-Provera, where it's a larger dose that shuts down both ovulation and bleeding, maybe I can get her disease to be better controlled. We've also seen this in inflammatory bowel disease patients, in multiple sclerosis patients. And so menstrual tracking and symptom tracking is an important part of disease management for these reproductive age women. I always have them either use a calendar or download an app where they can track their disease-related symptoms in combination with their menstrual symptoms. So we can figure out, is anything associated with your cycle? Is anything associated with ovulation? Is it worse on your heaviest bleeding days? And it really helps us to target their contraceptive use in order to have non-contraceptive benefits. Okay, the next part of it is availability of these methods. And this is where this program and additional programs that we're doing through the Family Planning Division to improve availability of these methods is really important. And provider training is huge. So part of it, again, the silos of care, making sure that regardless of your role in seeing that patient, if you're seeing a reproductive age patient, you need to be talking to her about her pregnancy plans and assessing whether she's thinking about pregnancy, what she's used before, and considering it part of disease management. Because even if you're the one who's just prescribing her chemotherapy, if she has an unintended pregnancy, that derails your plans for treating her disease. It's also related to provider training for all methods of contraception, including IUDs and implants. And even if you're not the one who's going to eventually be placing it, understanding what they are and how they work and the safety of them is important, because it often starts at the front desk with the scheduler answering questions about what the person's calling to schedule an appointment for, or talking to the person rooming the patient and asking questions. These personal perceptions and misinformation can really change a patient's beliefs about a method in a positive or negative way. And then another important aspect of availability is insurance. And this is where the women who fall in the gap and do not meet criteria for public insurance and may not have private insurance, they're really without access to these methods. And if they can get into one of our clinics that can provide sliding scale options, often their medical conditions are not well controlled because they haven't been coming in to get care for their chronic health conditions as well. And so it works both ways in making sure that we're able to provide preventive health care, provide disease management for their chronic health conditions, and then also make sure that they get the preventive contraceptive care that they need with the method of their choice in order to avoid unintended pregnancy. Now, for those of you who see patients, I totally recognize the provider limitations on this. It's really easy when a patient walks in the door and says, this is exactly what I want. And I'm asking for these long conversations to talk about their disease and their efficacy of the methods and what they've used before and side effect considerations. And I totally get it. And so, my goal is just to get people to recognize that there are options for screening, which do not have to go down the path of every single one of these topics unless you feel comfortable and have the time to do it. And so many individuals have tried to come up with a way to get providers to screen for pregnancy risk. And that's the biggest consideration. Like I said, regardless of who you are, even if you're a radiologist who doesn't actually see the patient, you need to know if the woman is at risk for pregnancy before doing any of your treatments or imaging that you might be doing that could risk a pregnancy if she doesn't know that she is or is planning for one. And so this is one example. It's not perfect, but this was developed by the Oregon Foundation for Reproductive Health. It's called the One Key Question, and it was really targeted towards primary care providers. And with the recognition that primary care providers are already being asked to screen for everything, smoking, domestic violence, vaccinations, et cetera, and here's one more thing to throw in the mix. So they tried to make it pretty straightforward, just asking, would you like to become pregnant the next year? And if they say yes, or they're ambivalent and they don't want anything to prevent pregnancy, but they are sexually active, making sure that you optimize their health in case they do have an unintended pregnancy. So reviewing their medications to make sure that they're not on something that's teratogenic, reviewing their health conditions to see if there's anything you can optimize. Maybe they haven't actually tightened their blood sugar control in diabetes, and yet here they're at risk for a pregnancy. Making sure they're on folic acid, maybe setting them up with an OBGYN or a maternal fetal medicine specialist to talk to them about pregnancy risks. So that way it's not an unintended pregnancy without information. And we can help them optimize their health along with pregnancy outcomes. And then if a patient says, no, I don't want a pregnancy in the next year, or I'm unsure, but I want to do something to prevent it, or maybe you're recommending that she not have a pregnancy in the next year. For example, she's receiving a chemotherapeutic agent for cancer treatment. She should not be pregnant while she's taking that drug. And yet she might not realize, again, the efficacy of different methods. And so talking with them about what they're actually using, their satisfaction with that, and reviewing all options, including these highly effective methods such as IUDs and implants is first line when you're talking to them and they have one of these high-risk conditions. And then another important consideration, regardless of which method they're using, is the importance of emergency contraception. I'm not sure if we talked about this in any of the previous lectures, but emergency contraception comes in a variety of different options. One of them is a copper IUD, and that's a highly effective and most effective form of emergency contraception, but also provides ongoing highly effective contraception. So again, you have to have access to that, though. So you have to be screening for it, know that they're at risk, and be able to get them into the copper IUD in within 5 days of unprotected sex in order for that to work. But if they're on another method, say they're on birth control pills, and they're at home, they realize they've forgotten a few pills, they had unprotected sex, knowing that they could still qualify for emergency contraception to decrease the risk of pregnancy is important. And for that, in that setting, if it's not an IUD, Plan B or ELA, which is ulipristal acetate, which is prescription only, are all safe regardless of chronic health condition. And there is information in the medical eligibility criteria about that. Okay, so before we get into a few minutes for questions, the take-home points for what I've reviewed over the past half hours, reproductive planning really needs to be integrated into disease management. Regardless of why you're seeing that patient, if they have one of these chronic health conditions, you need to ask about reproductive planning, risk, desire to prevent pregnancy, because nearly half of all pregnancies are unintended, and these are the patients who are at increased risk for adverse outcomes and modifiable adverse outcomes if we do a good job of screening and preconception counseling. And when you're talking to these patients, again, this is going to be a journey for them. Talking about their efficacy, safety, acceptability, and availability of all these methods is really important in ensuring that they have the method that fits their life, fits their disease, and something that they're going to continue to use. Because throwing a recommendation at somebody, even though, for example, LARC is first-line recommendation for those 21 diseases, that doesn't mean that that's the right method for every woman. And so she needs to know her options and the risks and benefits of each one of those in the setting of her condition. Okay, so let me just briefly go through the questions that we had sent out on the pretest, because I want to make sure that the take-home points are understood here. So the first question was, estrogen is found in which of the following hormonal contraceptive methods? And this is that breakdown of the methods I was talking about, of the estrogen-based methods versus the progestin-only methods. And so for answer A, hormonal IUD, the hormonal IUDs are Liletta, Mirena, Skyla, Kylena. All of these have levonorgestrel in it, which is only progestin. And so there is no estrogen in a hormonal IUD. It does not increase the risk of venous thromboembolism, MI, or stroke. So these are absolutely highly effective methods, which are safe in these medical conditions that contraindicate estrogen use. The copper IUD does not have any hormones in it, and so there is no estrogen or progestin in it. It is working because of the copper ions impacting sperm motility, and so it does not impact the hormonal cycle and does not increase risk of any adverse outcomes because of hormones. The contraceptive implant has etonogestrel in it, and so again, it's a progestin-only method. There is no estrogen in that, and the dose of it and the type of progestin is different from Depo-Provera. I've heard it described as a long-acting Depo shot, which is absolutely not true, because people who have tried Depo and have not been happy with it recognize that Depo is a big slug of progesterone with a lot of side effects to it, including weight gain, mood changes, etc. Etonogestrel, again, is a synthetic progestin. It's in a different progestin class. Remember that tree I showed you of the different classes there? And so we don't typically see the weight gain with it or the mood changes, but it does suppress ovulation. And so for patients who want ovulatory suppression or need it because of symptoms that are associated with it, it's a great option that's highly effective and long-acting, but does not have estrogen. And so the contraceptive patch is the correct answer to this. It has estrogen in it, ethinyl estradiol, and it has synthetic progestin in it. And so this is the one where if you have a contraindication to estrogen because of increased risk of blood clot, this is the one that increases that risk further. Okay, the next question was the CDC U.S. medical eligibility criteria for contraceptive use provides guidance on which of the following topics: contraceptive efficacy, safety, acceptability, and side effects. And so these are the different topics that are important to talk to your patients about. But as we went through with the guidance before, it provides evidence on safety. So it just ranks these methods 1 through 4 in the setting of this chronic health condition. How safe is that method? And it's, again, often based upon whether it has estrogen in it or not, and whether that disease increases risk of blood clot in the setting of estrogen. Whereas because it's ranking all of them, you can look across the different methods for efficacy, because now you are aware of the different tiers of the highly effective methods being the most effective, user-dependent methods in the middle, and the barrier methods or behavioral methods least effective. Contraceptive acceptability, while we ask about that with our patients and talk about that, is not listed at all in the ranking of the different methods. And contraceptive side effects are also not listed. So as contraceptive safety is the goal of the medical eligibility criteria. And so again, if you do not have this app, download it, play with it. I use it for teaching with our trainees all the time because it answers so many questions like, can I put an IUD in today in clinic? Well, let's see if we can be reasonably sure that this woman is not pregnant and it's a safe option for her. And what additional tests do we need to do ahead of time? And she has hypertension, so is this the right option for her? So now let's look at the medical eligibility criteria and see. So it's a great way to have hands-on advice for the patient, too, who might be concerned whether or not in the setting of their disease we can say a method is safe. Okay, so we're at 12:45 right now, so I will wrap up. This is my contact information and email. Please reach out if you have any questions. We do have our family planning fellows here specialize in seeing complex contraception patients in their clinics, and so if ever you have questions about any of these patients who might have a health condition and you have concerns about safety or options for contraception, please reach out and we will make sure that we either meet your needs with resources or see the patient here for a consult and send them back with some guidance. And so I'll take any questions anyone has. Is there a user box that?
Yeah, nothing's coming in yet. Anyone in the group have questions? People on the phone can also feel free to unmute yourself and verbalize your question if you'd like, or use the chat box feature to state your question.
Yeah, like, you know how like oregano kind of tastes like if you put too much oregano, you just get it off?
I do it.
Like dirty. Beets taste like dirt to me. Yeah, I think the kitchen does it now.
So I'm hearing that beets taste like dirt, which is definitely not on my topic area.
Here's a question. If we were to place an IUD same day of a consult, what are the criteria that a patient should meet to guarantee she isn't pregnant on that day?
All right, and that's a great question where the, I'm not sure, they probably couldn't hear you. And so the question was whether with a same-day IUD insertion, you can be reasonably sure that the patient is not pregnant. And so I, pull out my smartphone with my app, and if you open the CDC app and click on that, it brings you to options for the medical eligibility criteria by condition, by method, or the SPR, which is the selected practice recommendation. And so if you then click on that, your top line on that is how to be reasonably certain that a woman is not pregnant. And so there are different criteria on here that talk through the timing of their last menstrual cycle. And so if they're less than or equal to 7 days after the start of a normal menses, and normal meaning that they have regular interval menses, then you can be sure that, or reasonably sure, to use the right criteria, that a woman has not yet ovulated and you're not concerned about luteal phase pregnancy at the time of insertion. Also, if she swears she's been abstinent, she does not have a partner since her last normal menses, then you can, talk to her about, I need to know for sure, and make sure that you believe that she is reliable in her response, and you can go ahead and place that because she's not at risk for pregnancy. If she's been consistently or correctly using another form of contraception, so for example, say she's been on the pill and she's 2 weeks into her pill pack, you can go ahead and place the IUD if she hasn't had any missed pills that cycle. If she's less than or equal 7 days after a spontaneous or induced abortion, within 4 weeks postpartum, and then fully or nearly fully breastfeeding less than 6 months postpartum and still amenorrheic. So these are all the criteria that you can rely upon, and if you can always document this. I know that some clinics give pushback about a woman having to be on their menstrual cycle in order to place an IUD. This is evidence-based guidance to support your decision to place that the same day and not risk, again, placing it in a luteal phase pregnancy. Now, let's say you also want to make sure, though, that you're doing everything correct with the IUD and you're stopping her birth control pills. So if you then click back on the SPR, there's information about initiating an IUD or other methods, and under that, it talks about need for backup method. And so let's say she comes in, she's on week 2 of her pill, she's been a consistent correct user, you put in her IUD that day, you tell her she can stop her pills, although she might have some irregular bleeding from the estrogen withdrawal, stopping her pills. But then if she does stop her pills that day, she needs backup contraception because the IUD is not immediately working. So if you click on the IUD, it tells you exactly how long she needs to use backup for. So let's say she's within the first 7 days of her cycle, she doesn't need any backup. But in the case of this patient where you stopped her pill, she's greater than 7 days since her last cycle, and so she could potentially ovulate before the IUD is working well, and so we recommend that she use a backup method for the next 7 days. And this is where some people will say just finish out this pack of pills, take another 7 day of pills, whatever is easiest for that patient to get through that window, and then she can stop her pills and rely on that IUD. And then there's also information about, well, how can I be reasonably sure if she's amenorrheic? She doesn't have a great cycle timing. Then there's information on here about how to assess that. And so it's a great resource to answer all of your questions that are on the fly in the clinic too. There's also been some information about how to stop using contraceptives when a woman is perimenopausal too. So I hope that answers that question and also kind of goes through how to use the app, which should definitely be an essential part of your management of reproductive age women. Any other questions come in on that? Okay. One of the big questions that we often see for our complex contraception patients is many of our patients are on anticoagulation, and there's a concern about bleeding and method use for women who are anticoagulated. And so, one of the important things, again, is talking to them about what their goals are. For many of these methods, they cannot be pregnant, and so using a highly effective method is definitely important in the setting of these health conditions. But some of these methods lead to some irregular and annoying bleeding, and in the setting of anticoagulation, it can only be worse. And so for somebody who's fully anticoagulated, especially if her periods are heavy, I don't routinely place a copper IUD unless that's truly the only method that's a good option for her, just because it can increase the amount and duration of her bleeding. And especially if she's already borderline anemic from that bleeding, that might not be a safe option for her. So we talk about other options, including the hormonal IUD, and the fact that with a hormonal IUD, most women do have improvements in their bleeding, but if they're anticoagulated, it might not be as great as somebody who isn't, just because they're prone to more bleeding and heavier bleeding. And so they may never reach that amazing spot of being amenorrheic with hormonal IUD in place. With implant placement, there have been concerns about placement in anticoagulated patients just because they could form a hematoma at that site. It's not contraindicated, but we do take some extra precautions to make sure we're really looking carefully that we're not placing it over top of any venous areas or vascular areas. We hold some extra pressure on that area with a pressure dressing in order to minimize that risk and just warn them they might have some extra bleeding compared to somebody who's not anticoagulated. And then if somebody really wants to try to achieve amenorrhea, and especially if they have menstrual-related symptoms specific to ovulation, we'll often talk to them about using Depo-Provera because it's the most reliable way out of all the methods of suppressing ovulation and also achieving amenorrhea within about 6 to 12 months. Although, again, if somebody's anticoagulated, they may not fully achieve that, but their bleeding should be a lot better than it was before. So one of the other considerations that I've heard with complex contraception patients, especially in our autoimmune disease patients, is concern about immunosuppression and use of implants or IUDs, because here you're placing a foreign body in somebody who is immunosuppressed and might be at increased risk of infection. So often we'll get consults in the hospital of concern of coming and pulling this foreign body because a woman has a systemic infection. And what we actually see is that that's not the case, and we do routinely use them. Our data to support this comes from our HIV population, where they are immunocompromised, and also our renal transplant population, where they're on chronic immunosuppression to protect their transplanted organ. And we do not see an increased failure rate in these patients because there is some concern that there's kind of a local inflammatory response in the uterus that helps decrease pregnancy risk, but we don't see an increased failure rate, and we don't see an increased risk of infection. And in some ways, it's actually protective against sexually transmitted infections, especially in the setting of hormonal IUD, because it thickens cervical mucus, and after placement decreases risk of gonorrhea and chlamydia transmission because that cervical mucus doesn't allow those infections to ascend. And so it is absolutely safe to place them. That being said, if somebody has an ongoing infection, and especially a life-threatening infection, we will occasionally pull them, even if they've been in place for some time, just to decrease that theoretical risk. But we don't really have evidence to support that. And they are safe and should be a first-line option to avoid unintended pregnancy in these complex conditions that are definitely concerning in the setting of an unintended pregnancy. Other considerations that have come up are use of birth control pills, patches, rings, other hormonal methods in the setting of with other medications, and this is often a concern with patients. When it comes to birth control pills, there are very few medications that actually interact with birth control pills, either increasing metabolism or decreasing efficacy of those. Often there's some of the anti-epileptic medications or the HIV medications. And so if patients are on those, there is specific guidance in the medical eligibility criteria. And so it's not on the app, but there is a link to the desktop version of the MMWR through the CDC, where you could go in, and if this is part of your patient population, read very specific information on the safety and mechanism of action of these medications and interactions with them. But for routine antibiotic use, there's always this myth that I took antibiotics so my pill wasn't as effective. It's really our TB medications, our rifampin, Albuterol, that decrease efficacy of birth control pills. So routine antibiotic use is absolutely fine. But what can affect it is if women are sick, and that's why they're taking the antibiotics, and so they're not able to take or tolerate their birth control pills, and so that can interact. One way some of our chronic disease patients get around that is actually placing their birth control pills in the vagina for absorption instead of taking it orally. So if they have a GI upset or they're on antibiotics and they're concerned, the hormones get absorbed and avoid first pass effects through the liver, and so they are still effective for pregnancy prevention and bleeding control throughout that cycle without having to take an oral dosing if the woman can't tolerate it. Okay, 12:57. Do you have other wrap-up?
Yes, I'll just remind them. Okay. In case anybody didn't hear, I just want to remind everybody again that the CME credits do have to be claimed by midnight tonight. And if you don't get an email from me within the next half an hour, feel free to email me to let me know that you were here. Thank you, Dr. Gawron, for your time, and thanks everyone for joining. We're going to end the meeting.